Good morning, everyone. First of all, I'd like to thank Brittle Society for inviting me to speak today. And the topic I was asked to cover was quite broad, genetic diagnosis, but I thought what I would focus on is how we're trying to mainstream genetic testing within the NHS. And what I talk about mostly today would apply to NHS England, but what's going to happen is what happens in NHS England would obviously move into the devolved nations in due course. So it would be applicable to the rest of the UK as well. So to put it in context, I think first of all, we'd have to look at the communication evolution. And I think many of us in the audience will remember the good old days where all you could do in terms of communication was sending a postcard. And then things evolved, which meant, we had access to what were called landlines and we were able to communicate with each other. And of course, nowadays we've got mobile phones and whatnot with the latest technologies. But I think some of us do miss the good old days where you promised to meet a friend at a specific place, you turned up, and there was no way of canceling last minute. But of course, it has got its own advantages. There are several reasons why the evolution of communication has transformed our lives, as the Zoom meeting is there to illustrate. So similarly, if you look at the concept of how genetics has evolved over the last sort of 60 years or so, we've come on huge leaps and bounds. If you look at when in 1950s, Watson and Crick decoded the double helix model of the DNA, and if you look at where we are now in terms of service genomic testing and being able to do whole genome sequencing in an NHS clinic, it has transformed our genetic practice. So there's a couple of terms that we use interchangeably, and I thought it would be quite helpful to sort of try and differentiate between these two terms. Normally, what we talk about is genetics, and that is, so I call myself a clinical geneticist, and that's the study of heredity. It is the function and composition of single genes that we're interested in, which has got a very specific function in the body. Now, what is a gene? It is a specific sequence of the DNA molecule that's got a start codon and a stop codon, and it has a very specific function in the body by encoding for a specific protein. In OI, this is type 1 collagen. But of course, if you look at genomics, which is the sort of more fanciful word that's used at the moment, it is study of an organism's complete set of genetic information. And of course, here we're talking about humans. And the genome includes both the coding and non-coding parts of the DNA. And I'll talk about it a bit later on. So the genome is essentially the complete genetic information of an organism, not just one or two genes. So if you look at all living things, we've got a genome which is made up of DNA, and it's got instructions to build and repair our bodies. And what I always say to our patients is, of course, the DNA characteristics determine how our eye color is, our hair color is. All of these instructions are coming from these specific genes. And also it influences our susceptibility to develop a disease, or sometimes there are protective factors within our genetic code. That means we don't develop disease. So for example, in the sub-Saharan African population, they've got a genetic variation. That means they're protected against falciparum malaria. But it is important to remember that not all variations cause disease. So quite a lot of our time is spent on interpreting variants and looking at variants and saying, do they actually cause the condition? And again, important to remember that only 0.1% of our genetic material is different between two individuals, but that roughly equates to about 3 million differences within our DNA. So although it's only a tiny bit that makes us unique, that equates to quite a bit of our genetic material that's different. So this is quite a useful slide to look at how genetic testing has evolved and what are we looking at. And I think the segment, the orange segment on the side, is quite a useful comparison. So if you look at what used to traditionally happen in the genetics clinic, or when we talked about genetic testing, we were only looking at that small segment of orange. So we were doing single gene sequencing, where if we had a strong suspicion of a gene being involved, or if there was a strong family history and we knew that there was a specific genetic variant in the family, we could go testing just for that. So this would be the case with OI. But of course, testing moved on in the last decade or so, where we were able to have targeted gene panel testing. So we were able to look at a whole host of genes. So for example, 20, 25 odd genes that are involved in OI, which was linked to a particular phenotype here. We're talking about bone fragility. And then things moved on, which meant we were able to then access this technology called whole exome sequencing, or exomes, where we were able to look at just the protein coding, so-called exome parts of the genome. And so, for example, the DDD study, Deciphering Developmental Disorder study, was focused on that. And why looking at the exome was useful? Because this was a great way to discover new genes associated with different conditions like OI. But now where things have moved on is we've got genome sequencing, where we're able to look at both the coding and non-coding parts of the genome. An example of that would be the 100,000 Genomes Project, which I know some of the participants may have been involved in. So just a little bit more on whole genome sequencing. Like I said, we've got about 20,000 protein coding genes, and although there are 20,000 pairs of genes, they make up only about 1% of our whole genome. The remaining 99% was what was called junk DNA or dark matter, but we now know that it has got regulatory elements in it, which are equally important. But again, most disease-causing genes sit within that 1% of the protein coding parts of the genome. So like I said, whole exome sequencing looks at just the protein coding parts. The whole genome sequencing looks at both the coding and non-coding parts of the genome. So what has changed? In March 2017, NHS England set out a plan to build a national genomic medicine service, and it was mainly building on the experience gathered from the 100,000 Genomes Project. And the plan was to set up a network of genomic laboratory hubs, a bit like a hub and spoke model. So there were certain labs that became hubs, and then the remaining labs, because there was a lot of labs distributed throughout the country. And this was going to underpin how test was requested. So we've got a national genomic test directory now, and a national whole genome sequencing provision for quite a lot of referral criteria. And OI hasn't got there yet, but it will happen in due course. And again, having the informatics, bioinformatics, which is the big thing in data interpretation infrastructure, which was developed in partnership with Genomics England. And where do we come in? So we've got the clinical genomic medicine service, which was then going to be set up as a genomic medicine center service. And this was all being coordinated nationally within NHS England. So of course, I work at Sheffield, and I'm based at the Sheffield Clinical Genetics Service. So we now sit under the Yorkshire and Humber, and this is happening across the nation. So we link up with the Northeast and North Cumbria. So mostly they are huge, big regions that are being covered. And like I said, they've established these new network of laboratory hubs. But the clinical genetics service of what's happening on the ground hasn't changed that much. So we've still got the specialist clinical genetic centers, which are based in different cities. So here we've got Leeds, Newcastle, and Sheffield. And I think where this is going to start to change is an increasing role in supporting mainstream colleagues with specialty-specific MDTs, results interpretation, that sort of thing. And we've now set up what's called a Genomic Medicine Service Alliance, which includes lots of the trust within the region, hospital trust. And of course, we sit within the Northeastern Yorkshire GMSA. And it's all about how we're going to coordinate and oversee embedding of genomics within the mainstream clinical practice. And the ultimate aim is to be able to provide a link to personalized medicine. So if you knew what the underlying genetic basis was, you would have treatments tailored to that particular genetic etiology. So if you look at the aims of this whole enterprise, it's all about enabling quicker diagnosis, making access to genetic testing more equitable, which wasn't always the case. Improving outcomes for patients, especially the focus is on cancer outcomes, but of course it means everything healthcare related, having a very patient-centered approach, promoting research, especially access to genomic research, and collaborative working between different hospitals. So that underpins all of this enterprise. So what are the new developments? Like I said, we've now got the National Test Directory, which sort of stipulates who can request testing, who are the patients that would be eligible for such testing, and how are the testing being offered. And like I said, whole genome sequencing is starting to be offered as a diagnostic test, but this is only for certain referrals. So at the moment, it is mainly for intellectual disability, certain neurology conditions that it's being offered. The other thing that's come out of this is this understanding that acutely unwell children need more rapid access to genetic testing, and we need quicker results. So you can imagine if there's a prenatal or postnatal situation where you've got a child with OI, a neonate with OI, we need quicker results. So we've got what's called R14, rapid whole exome sequencing, which allows us to get this within a couple of weeks. And then the main number to remember, so to speak, is R102, which is the OI panel testing, and also R104, which is where the skeletal dysplasia testing request sits. But then there are about 400 or 500 genes to look at. So what we need to do is stop slicing for specific genes. So for example, here it would be genes that are involved in bone fragility. So the National Test Directory was launched in 2018, and then of course with COVID, there was quite a bit of delay. So we've had that operational since the last year or so. And it specifies, like I said, which genomic tests are commissioned by NHS England, so which are the tests that are already paid for, and technology by which they're available, and patients that would be eligible for such testing. And it would contain all these tests that are offered by the GLH, and there's an IT system underpinning these requests. So why these changes? If you look at previously what used to happen with genetic testing, or as we call it now, genomic testing, it was taking place quite a bit outside specialist genetic clinics. So it meant that there was quite a lot of discrepancy between what testing was offered, what technology was used. There wasn't a national standard framework for this. And access to genomic research was variable depending on where you were seen. Was that a specialist center, and did they have a specific interest in that particular condition? But with 100,000 Genomes Project, at least people that participated, they should have all received their initial results. And currently we are reporting additional findings. We've now got the 7 genomic laboratory hubs that have been created, a national test directory, which we've introduced, and whole genome sequencing is being offered now as a diagnostic test. And we've got the GMSAs that have all recently formed and in place. So what are the benefits of doing this? Of course, it's involved a lot of time and money, as you can imagine. But I suppose the benefits are increased understanding of the genetic causes of disease, improved availability and types of testing that are being offered. So it's all with the latest technology. Increasing possibility to tailor management and treatment specific to the individual's genetic cause, and place more diagnostic testing into mainstream specialties. This is key because there are very few geneticists, and so we can't be gatekeeping all the genetic tests, and we're not experts in all the genetic conditions. So I know quite a lot about OI, but perhaps don't know that much about immunology conditions. So it's placing more diagnostic testing into specialties that are experts in those conditions, and enabling new treatments to be developed. But it comes with its own challenges. The main challenge is this understanding that although you've got whole genome sequencing, you're still only looking at limited amount of data. So it's still a targeted gene approach, but just have all that sequencing data to access. It's also educating clinicians who may not have much experience or knowledge of genetics, so be able to interpret quite complex results, and making sure we avoid overinterpretation or misinterpretation of these complex results. So you can imagine a situation, we've had several examples where the mainstream clinician copies and pastes a complex report and sends it off to the patient. And that causes quite a lot of anxiety and confusion in terms of interpretation of these results. So that's something that we've been working on with the genomics education program, putting out a lot of information out there. So just focusing on R102, this is what the National Test Directory criteria looks like. And although at the moment the requesting specialty still says clinical genetics, there's a lot of background work, and very soon lots of the mainstream clinicians, particularly musculoskeletal experts involved in pediatrics as well as adult healthcare, would be able to request this testing. It's still done as a targeted panel, so that hasn't changed, but in due course, it'll all move towards whole genome sequencing with application of targeted gene panels. So what are the practical aspects? Like I said, there's a lot of work mainstreaming genomic testing so that initially the specialist, but in due course, your GP should be able to request genetic testing. That's not happening yet, but will happen in due course. The other thing that's changed is there was a lot of emphasis on consent for genetic testing and what patients are agreeing to sign up when they do the genetic test. But that has changed because we can't consent for something we don't know what we're going to pick up. So now it's called record of discussion, RODs. And the emphasis is to include what's called variants of uncertain significance, which can be picked up on genetic testing, and discussion around what will happen if a variant of uncertain significance is picked up, how would we interpret that variant? What would we do in terms of further studies? And there's a new test request form with details like the R102 that needs to be filled in. Cost is no longer a barrier to testing. So where previously I've had emails from members of the Brittle Bone Society saying my GP will not request this testing, or my genetic center will not approve such testing because of the cost involved, that shouldn't be a barrier anymore. Important to remember that genetic testing is not to be used as an exclusion test, because it is not suitable for that, especially because you can pick up variants of uncertain significance that will still need interpreting. So of course, clinical phenotyping and correlating with the clinical information will still remain key. I'm happy to take any questions. Thank you for your attention.